Hi, friends. Good evening to all of you, and welcome for the CME today. The speaker of the CME, as all of you know, is going to be Dr. Harshad Kamath, and he's going to talk on a very, very important topic today, which is MISC, multi-inflammatory syndrome in children. We are in the second phase of COVID. That's almost about a month after COVID, and also we are anticipating a third pediatric wave. And what happens is, in this wave, as I had sent a message to you after discussing with Dr. Harshad, we need to keep our eyes and ears and mind open to this concept of MISC because the presentations are varied. And as all of you know, we are looking at an age group which we call a pediatric age group, which in India ranges up to 19 years of age. In UK, it is even up to 21 years of age. So what happens is, between these 14 and 19 or 20 years of age group, uh, parents as well as the so-called adults, that's after 18, they don't know whether they need to see a pediatrician or whether they need to see a general physician or a physician. So what happens is, there is a lot of confusion, and we all, in this confusion, a lot of us can actually miss the diagnosing MISC and save a life. So the whole idea of this CME is to keep our eyes, ears, and the mind open once we know the concept. Because in the last 1 month, I think Dr. Harshad will share it with you, and there are other doctors also who are aware of these cases, wherein it has been a dilemma in the diagnosis, and many a times these type of cases are missed, and we are too late in treating the patient. So that's been the whole idea. Also, I would like to tell you all that Dr. Harshad is also on the state task force group for the anticipated third wave in preparing various modules. And I think he has very graciously accepted to take this up, because I'm sure he must be already overburdened, because he has been talking to a lot of people and he's been attending various meetings, and yet he has, squeezed in this time, and he's like, the whole idea is, even he feels that everybody, all of us should know it, because a patient can land up with anybody. Patient can land up with acute abdomen, patient can land up with a surgeon, a sonologist, a pathologist, a physician, a general practitioner, and we need to know about this. Well, Dr. Harshad, I don't think any of us on this group requires a formal introduction. Nevertheless, I'm doing my duty, Harshad. Harshad we have to know how illustrious he is. First of all, he's my classmate. So I'm always very privileged and happy to introduce him. So he finished his MBBS, though let me tell you, friends, that he joined Goa Medical College, and maybe he didn't like us so much, and so he shifted to Mumbai within, I think, a week or so. So he went to Grant Medical College and did his MBBS from Grant Medical College, finished his DCH again from the same college, and he, both in his DCH and in his MD, he topped in the university. And I think, and that's a great feat, to be topping in DCH and MD. Later on, he finished his DNB, and then post MD, he has worked in some very good hospitals like Hinduja Hospital, Bhatia Hospital. Then he has been abroad for a while. For the last 22 years, he's been a consultant pediatrician and neonatologist in Madgaon, and he has been running his own 14-bedded pediatric nursing home. He has been as an executive member on various committees of Indian Association of Pediatrics, also been on the executive committee and in the organization of a number of pedicons that they have organized. He has been a faculty and conducted huge number of CMEs, Maharashtra IP CME, Mahapidicon, IIP Goa CME, and I think I'll be only sort of wasting time, and Harshad is already showing me a scissor, saying cut it kind of a thing. So, and then of course he has been an IIP trainer. I think that's a very important qualification to his biodata. He has been an IIP trainer, and he has been talking on various things like pediatric infectious diseases, then rational antibiotic practice. That's very important, and management of childhood tuberculosis. And and now he's also been a chairperson of various sessions at national conferences. He's also attended international conferences, and now his field of interest has been vaccinology and respiratory illnesses and infectious diseases. Friends, he's been on the task force of the Goa government as far as the pediatric third wave that they are anticipating, and preparing everybody for that. He's been preparing various modules so that it becomes easier for everybody to look at this the management part of it. So I welcome you, Dr. Harshad. Thank you for your time, and please stay tuned after the CME, because Dr. Priyanka has put in a lot of hard work in bringing something very innovative to all of you. So let's begin with the academic session first. And again, welcome everybody. Welcome, Dr. Harshad. On to you.
Thank you, Dr. Babita, for a very elaborate introduction. Small correction, I'm not on the task force, I'm only on the expert committee. The task force is a lot more elaborate, which we report to. And of course, I'm just the opening act before Dr. Priyanka's fantastic performance too, with a lot of, anyway, that's a surprise, so I shall leave it at that. So I shall begin the topic, and I'll just start sharing my slides. So good evening, friends. So the whole idea of making this topic relevant is because this condition called as MIS-C, or called as MIS-C, is basically a multi-system inflammatory syndrome in children. And it's something that we are all going to be facing with this. And that's why I thought appropriate that we get acquainted with this condition. Let me first take you to a cartoon, and I'm sure you've all seen this before. And you're familiar with the old adage that if you have an elephant in the room and you don't look for it, you might easily miss it. So it's better that we know what the MIS-C is all about. At the same time, we should not get paranoid and start thinking about it all the time. More importantly, let me take you to this very, very important 6 doctors who are here. And I've chosen them very, very specifically. This is our affable, amiable, nice, gentle pediatrician. He is looking for MIS-C all the time because he has been sensitized to it. But beyond him, this is not definitely a pediatric problem. There are other doctors who will necessarily have to look for it. This is our family practitioners, burdened by the load of so many illnesses that you see. Just a second, I'm trying to get a marker here. Okay, so that's better. This is our friendly family practitioner, and you can see that he is the one who is going to see many of the MIS-Cs in the initial presentation, because by far the presentation is very common in children about 5 years to about 18, 19, 20 years. And this is the group who generally first visit the general practitioner. So they need to pay attention because they are going to see these patients. Then I'm sure if you look here, the most dynamic, the most assertive, and the most, well, let me put it this way, rather well-nourished looking individual is, I don't know what's happening, 1 second. I think I've got, is of course the physicians and the surgeons. They, I must, of course, this is stunning chick, but they are doing a fabulous job in managing all the COVID. But they should not forget that they are also going to see MIS-Cs, because many of them present in the age group between 10 to 20 years and beyond also. There are adults who can face this problem. So I'm sure they are going to be acquainted. And the surgeons, I can't forget them, because acute abdomen is a classical presentation of MIS-C, and they are going to see this problem also. Then comes the top of the line, are the highest of the pecking order, the super specialists. The cardiologists are going to see patients coming with cardiac dysfunction. The neurologists are going to see patients coming to them with various symptoms like headache and meningismus and hallucinations, ataxia, etc. Then we have the guy who's climbing up the ladder to success, the radiologist. See, the patients may come, nowadays patients go straight away. They have severe abdominal pain, they don't come to us. They will first go to the radiologist, get an ultrasound down, then they will come to us with us, oh, the ultrasound is normal. So the radiologist may be the first person to see, and he looks at the patient with severe abdomen, finds a thing there, takes a short history and finds there's a fever going on. Oh, could this be MIS-C? So that's when he can actually sound off the patient and the referring doctor too. Last but not the least, and I'm sure Babita will not take offense to this, because someone who has anybody by the tail is actually holding that person fully in control. Without the pathologist confirming the diagnosis, there's no way we can proceed further. I just hope, Babita, that assures you that this is no affront that you have been kept at the back, but all of us are going to face this problem, and all of us as a team need to look at this condition, because more often than not, it's a multi-pronged, multi-team approach. So jokes aside, let's come to the main agenda of today. That's how I'm going to go across this topic, is to see who should we label as a MIS-C. Then I'll give you a short diagnostic approach. Then we'll go at a management approach. Then through 5 short cases, which are going to illustrate 5 important lessons that we want to learn from this. And I'm sure that I'm going to confuse many of our friends here. So I've decided to show a short, small office practice approach so as to keep things simple and sweet. So short history, it was first described last year, about 1 year, 2 months back on the 7th of April, when Jones et al. First described the COVID-19 fall patient having what is known as Kawasaki disease. And following that, a few weeks later, the UK, Italy, USA all sounded alert, and it all came in the papers that there's something called a multi-system inflammatory syndrome. In the UK, they called it, because the Brits are obviously very high on terms, they called it pediatric inflammatory multi-system syndrome temporally associated with COVID. So that's how they called it PIMS-TS. MIS-C is what is now universally called by WHO and by all of us. In India, the first case was detected in Chennai in May 2020. What is important is that this disease follows 2 to 6 weeks after COVID-19 infection. This is important. And I cannot reiterate and say it more categorically. This is an uncommon disease. We should not be looking for it next tomorrow, because I've spoken on this tomorrow. Every fever should not be MIS-C. You have to follow your pre-pandemic approach to fevers as you looked at it. But bear in mind that you might be seeing a MIS-C, and I will show you how you can think about it. Now, this is just simple statistics for you. This is UK data that if there are below 21 years, the incidence of COVID was 322 per lakh. Then the incidence of MIS-C in the same population is only 2 per lakh. That translates it to approximately 1 case of MIS-C for every 100 to 200 pediatric patients or below 21-year age. So this is not a very common, rather I would say it's a very uncommon condition. At the same time, it's important to identify it because of its presentation and how fast it can deteriorate. Most of these patients will have antibody test positive, while some will still have the RT-PCR positive, because if this patient presents early at about 2 weeks of age, you might have a positive RT-PCR, but he'll be non-infectious. But this is how you may have. So presence of RT-PCR positive can confuse the picture. You are then wondering, are you dealing with an acute COVID or are you dealing with a MIS-C? And this is more so a problem in the older patients. And that is why a detailed clinical history and proper analysis is important. We will look at the whole approach shortly. So what is the definition of MIS-C? There are 6 criteria. First is the age. WHO said 19, CD says 20, UK says 21. These are all important only for statistical analysis when they want to know how many. But for us, remember, right from birth to patients up till 50 years, all are known to have MIS-C predominantly in the age group below 19 years. Second important criteria is the patient should have fever for at least 3 days. The inflammatory markers have to be positive. There should be a direct correlation with COVID-19. At least more than, it's a multi-system after all, so there should be more than 2 systems affected. And you should rule out all other causes before you call it MIS-C, because this is a diagnosis of exclusion. Now, this is the slide of all what the WHO has elaborated, but I'm going to take you through each of these criteria in a broken down manner so that this registers fully. Let's understand this criteria better. First of all, if you see the age criteria, as I've already told you, there is something called as a MIS-N for the newborns, there is MIS-A for the adults, but the vast majority are your MIS-C. So age, though, is important for MIS-C, is not so much of a problem when you're talking all about all the age groups that we are going to see as a collective physician group. If you see the UK data, this Ramanan is a very famous rheumatologist from the Bristol NHS, and his data of around 100 patients, the median age was 8, with an average going from 6 months to 21 years. I've just chosen a couple of data from here and there. This is from Delhi Gangaram Hospital. Dhiren Gupta and all in team had a median age of 6.7 years. So this is the average age that you can expect patients to present at. Second important criteria is that patient should have fever. Now, in our national commonest thermometer being the back of your palm, many a times this data does not come forthwith. So you cannot strictly say 3 days, 101 fever. You can opt to use maybe 2 days, 3 days or lesser. If you have a clinical suspicion, then go ahead. All I'm trying to say is that last year when MIS-C criteria came out, it was very strict that you need to follow these strictly. But now the realization dawned upon all of us that MIS-C criteria should be used more like a screening device. The sensitivity and specificity cannot be 100%. So if you have an overall suspicion of MIS-C and you have ruled out all of the usual suspects, then your diagnosis is tenable. So having said that, look at patients. Usually they will have high grade fever, usually more than 101, going beyond 3 days, but it's a persistent fever. It's not the fever has come on the first day, next day no fever, third day again fever has come. You're more likely to deal with malaria in that case when you have interrupted fevers. But this is persistent fever. Next important point is to have more than 2 systems affected to make it multi-system. So which are the common systems affected and how is the usual presentation? The classical presentation is what is known as the Kawasaki disease. This is how the first MIS-Cs were identified, and this is what we call the Kawasaki disease phenotype. Now, I'll show you what Kawasaki looks like. Kawasaki is a disease obviously first described in Japan, very common in children below 5 years. But when you see children above the age of 5 years with similar features, that is when you think of MIS-C. Look at these features. First of all, you have mucositis. There's inflammation and exudation in the mucosa. Red lips, almost where the child is wearing a lipstick. You see somebody coming at 8 years wearing lipstick kind of glossitis or on the lips looking very, very inflamed. This is one of the features. Look at his BCG scar. It might have got reactivated, looking inflamed again. This is another feature of Kawasaki. Polymorphous rash. Swelling of the hands looking like what is described typically as IV fluid out, extravasation type fluid out situation. So you see this swelling of the hands, and later on you may have desquamation on the fingers. Very, very important, very characteristic is to see these red eyes. This is called conjunctival hyperemia. I'm going to show a better picture on this shortly further on, but these are what are known as the Kawasaki features. Along with these, you have lymph nodes, of course, fever, age. So these are the criteria for Kawasaki. And this is by far the commonest presentation. This is what you must remember seen in a child over 5 years. This is how you would see a MIS-C presenting. Next important phenotype would be a child presenting in shock or hypotension. This is a characteristic feature. This may be the way the child would present to you. Suddenly the child would say, oh, fever for 3-4 days, and now he's just collapsed, and you will find the child is in shock. This is the way they can present also. This is what makes it scary. And that is why we should all be aware of this entity. The third presentation, which is very, very characteristic, is a cardiac presentation, wherein the child will present with a myocardial dysfunction or valvulitis or pericarditis or all of it together like a pericarditis. And CAA stands for coronary artery aneurysms. So this is also an important point where children develop aneurysms following MIS-C. If not that, you may actually have evidence on lab to suggest cardiac involvement by the elevation of TROP-I and pro-BNP, which incidentally will happen earlier than the clinical manifestations are evident. So it's very important to look for this when you have a characteristic feature suggestive of MIS-C. Mind you well that you may have mixed presentation. A KD can develop into shock, a cardiac patient can go into shock, or a cardiac patient may develop KD features. So you can have mixed pattern here of presentations also. Next very characteristic presentation is your GI. It's an acute abdomen, almost like a surgical abdomen. This is one characteristic point of presentation. Also, the child may present with vomiting, loose motions. See, all these features come about because of a cascade of liberation of interleukins, which cause sort of a spasmodic pain in children, or it could be inflammation in the mesenteric adenitis, or simply peritoneal inflammation, or because it's an inflammatory condition. So various types of presentation that you will see. And lastly, the characteristic presentation is coagulopathy. Bear in mind, this is not thrombosis. In children, it's very uncommon. Coagulopathy that I'm talking to you about is elevation of PT, PTT, and D dimers. So more of a laboratory identification of coagulopathy rather than clear-cut thrombosis, as happens in adults. Adults are, of course, thrombogenic in their character, unlike children. So I have told you about what are the characteristic presentations, but there are some other presentations which are not characteristic, and these don't feature in the WHO definition. So this is why I've added this separately. It can present as hepatitis or as an add-on to other earlier presentation. This may also be there. There may be kidney injury, there may be neurological manifestations, and characteristically very dangerous is a presentation called HLH, which is nothing as hemophagocytic lymphohistiocytosis. Basically, I will tell you about the features shortly. I'm not going to detail this, but this is one of the dangerous manifestations of various diseases like dengue, and even in rheumatological conditions like macrophage activation syndrome, a similar condition to that. Bear in mind, very characteristically, respiratory system is usually not affected. Unlike acute COVID, somehow the respiratory system escapes the brunt of this multi-system disorder. So I've gone through the three criteria of age, temperature, the fever, and the clinical presentations. And I'll take you next to lab evidence. First of all, it's clear that we are not going to investigate this fully, all the investigation. We should do first a screening evaluation. What is a screening evaluation? You will do a complete blood count, a complete metabolic profile that includes the liver test, the kidney test, the blood gas, the glucose. You look at the basic inflammatory markers, the CRP, ESR, and of course, look for evidence of COVID. Now, why so? It's important because these guidelines that I'm talking to you about are the Indian Academy of Pediatric guidelines, which have also been commissioned by the Ministry of Health and Family Welfare, and the ICMR has ratified it. So today, whatever I'm talking to you about are the updated current IAP guidelines, also advocated by the Ministry of Health. And these are all borrowed from international guidelines. So this is what I'm talking about. This is not coming from my head. These are current guidelines. So these are the current screening evaluation. Only if the patient passes the screening evaluation, then you are in business of diagnosing MIS-C. If the patient fails in this, then you do not proceed further. So what do you expect in this evaluation? Number one, as you said, both of these two, 1 and 2, at least one of these has to be present, meaning thereby that your CRP has to be elevated 5 milligram per deciliter or 50 milligrams per liter, because whichever criteria you're following, 5 or 50, we normally use 50 per liter. So I should say, call this 50, and a ESR more than 40, then you know you have significant inflammation. If your CRP is 10, 20, please, that is not characteristic of MIS-C, but bear in mind, MIS-C is a diagnosis of evolution also. So if you have a patient on the third day with a CRP of say 20 or 30 at that point and not fitting into the criteria, and you don't call him MIS-C at that point in time, please don't write off. It's not an exclusion of diagnosis. You need to re-evaluate, reassess, re-investigate so that you can then decide this is MIS-C or not. So positive inflammatory markers and at least one of the initial these tests. Lymphopenia is characteristic. platelets low is important, but remember the platelets are not, it's usually between 1 to 1.5 lakhs. You don't usually get platelets like 50,000, 60,000 or 80,000. That's not characteristic. Sodium is low. Now, why should sodium be low in these patients? Remember, BNP. BNP is your brain natriuretic peptide. So in patients when the natriuretic goes up, which is a very, very common occurrence, you will have natriuresis, so sodium goes down. Neutrophilia of the lymphopenia there will be neutrophilia, of course, this patient. And hypoalbuminemia. This is, of course, a marker of inflammation when the albumin leaks out as a capillary leak phenomenon. So these are the features which will be important for you to screen. If you have got a positive there, next you should look at what are the COVID positive. Either the antibody is positive or the antigen is positive or the RT-PCR is positive. Sometimes the WHO has also said if you have a contact positive, then also you can take it as a positive. Remember, there are case series wherein there are patients who are neither RT-PCR positive nor antibody positive. They don't somehow have reacted that well, but evidence of contact was enough to label the patient MIS-C, having ruled out all other etiologies. This is important. You must rule out all etiologies. The usual suspects are malaria, dengue, blood culture for typhoid, urine infection, pneumonias, ultrasound for other kind of problem like an abscess or so, and in such situations you might have to consider leptospirosis, etc. So these are the 6 criteria. Unless and until the patient fulfills this criteria, your diagnosis does not become tenable. But at the same time, like I said, clinical acumen is important. Sometimes you have what is like an incomplete MIS-C, but then to label that, you must exclude everything else, then consider it. So once you have diagnosed MIS-C, then you can go for the tier 2 investigations, which are more elaborate, where we'll do ECG, echocardiography, or myocardial markers for BNP, TROPI. All your inflammatory markers can be done here. A blood smear. Blood smear is not for malaria only, but for what was known as almost a microangiopathic cytology, will you see on this picture. And of course, if you're not done earlier, you can do SARS-CoV and serology also. So these are the various presentations which I've already talked to you about. So going forward, I must tell you a couple of things. There is a potential for overdiagnosis because, as you know, many children are going to be COVID antibodies. I was speaking to Dr. Ira today itself in the meeting. Dr. Ira at Hospicio has done a ongoing study of serology to patients presenting at Hospice. Out of 500 children that they have screened for the antibodies against COVID, nearly 20% have become positive. Now, mind you, these are patients who have come for routine vaccination or checkups. They didn't come for fevers per se, and these are suggestive. At least about 20% of the kids are already positive. So just because somebody gets fever and I do antibody positive, that is not MIS-C. It's important that you fulfill all the criteria. It's important to rule out these common infections, and there is a potential underdiagnosis also because this was not in the WHO criteria originally. So bear in mind these conditions. There are some close mimics you should bear in mind: toxic shock syndrome because of strep and staph, tropical infections, viral myocarditis, and early phase of rheumatoid illnesses like systemic onset GIA, SLE, and macrophage activation syndrome. So this is an important slide for you to bear in mind. There are 3 classical presentations where we discern into. One is the KD-like picture as a Kawasaki-like disease. Second is your shock-like presentation. And the most confusing is this middle chap here. That is known as your febrile inflammatory state. These are children who have persistently high fever. They show inflammatory markers positive. There's a COVID history positive in this patient or antibody positive. But I am not able to find 2 or more systems affected, which means this is a child in the inflammatory phase, probably going to evolve into one of these or some other presentation. But this is a milder MIS-C, and that is why we have to wait for this disease to evolve. And this creates a headache to all of us, and I will show further on how we approach this patient. So, pathophysiology. Now, if I have to summarize the pathophysiology in one slide, then this is it. Missing evidence. We have no idea as of now what exactly causes it, and therefore Having shown you this slide, I'm going to fast forward the pathophysiology because it's all to do with immune dysregulation, antibody enhancement, and T cell mediated damage. I am not going to dwell upon these slides, and I will take you straight forward to clinical approach. Now, this is, of course, the most important thing. It's a busy slide, so stay with me. If you suspect Miss C, that means the child has come with fever, age is correct, COVID positive contact, how do you do the next step? You will proceed for workup, but remember simultaneously look at other etiologies along with this, the common etiologies. If you have a presentation which is characteristic like shock, KD phenotype, multi-organ dysfunction, then you don't waste time. You will do all the investigations. Remember, I told you about tier 1, tier 2 tests, and you do screening. If positive, you go for tier 2. You will not get the time in patients who are in shock. So such patients, don't wait, ask all the tests at one go. But on the other hand, if your patient is stable, hemodynamically, patient is alert, just having fever going on, and you have a suspicion because it's complaint of some vomiting, abdominal pain, some rash on the body, you will ask only for the tier 1, confirm that he has got those two that I talked about, inflammatory markers and one of these positive. Only in those patients you will go forward because now you're looking at complete multi-system involvement is there or not. So coagulation profile, cardiac profile, all those things you would do only if this is positive. On the other hand, what happens if the patient does not show positivity in the tier 1 test? Yes, you are not able to call him Miss C at this point of time. So you will work up for alternate diagnosis, and very, very importantly, don't send this patient out of your purview of realm of Miss C. You will monitor for evolution of Miss C. Very important you do that. I hope that's clear. In fact, if anybody has questions at any point of time, feel free. I find it very boring to address a screen all the time. So any interactions, interjections are almost welcome. So there are certain caveats that I would like to leave with you. A very, very important slide for you to pay attention to. If you see patients with this presentation having cytopenias, either bicytopenia or tricytopenias, high triglycerides, high D-dimers, and very high ferritin. I'm talking about thousands. You may have ferritin of 8,000, 10,000 dimers in that range. You are suspecting hemophagocytic lymphohistiocytosis. So this is something that you must bear in mind. They can coexist. As you have seen, we are, unlike the adult colleagues, we are not advocating IL-6 much because CRP is what is called a poor man's IL-6. Please bear in mind, interleukin-6 will act on the liver to synthesize CRP. So CRP is your end product. If CRP is such an easy, cheap test as compared to this, we should be doing CRP more often. It's a good enough marker. Only in select special conditions, we'll need to do IL-6, which I'll talk to you a little later about. Very, very importantly, D-dimers. And I'm sure all of you by now managing COVID patients on the telephone, all are sensitized to having D-dimer reports high, and then you advise Clexane to these patients. D-dimers, please remember, only tells you endothelial cell activation. It's a marker of inflammation of the endothelial cells. It is purely a diagnostic consideration for Miss C. And I'm talking about children. In children, the level of D-dimer does not tell us that we should start this patient on enoxaparin. It does not. And I shall again reiterate, level of D-dimer does not dictate the need for D. It is only useful for us to say, yes, there is coagulopathy. Yes, this is one of the criteria fitting in. That's all. Next, very important is your TROP-I and pro-BNPs. Very, very important because this myocardial injury proxy tells us that this patient is very, very close to having a myocardial dysfunction and go into shock. Higher the level of pro-BNP, bear in mind, very important, this patient can desaturate or decompensate any point of time. Watch out for such patients. In fact, I would say if your patient with Miss C has high pro-BNP, you should be watching him very, very closely. And very importantly, this is something which creates a lot of confusion. Procalcitonin, we have all been taught, we've all been practicing, is a marker of bacterial sepsis. That is true if you're going to compare it with a normal viral infection. So between a viral infection and a bacterial infection, PCT is higher with bacterial infection. But that is because bacterial infections have higher inflammation. In a super inflammatory condition like MIS-C, PCT is going to be high any which case. So you cannot use PCT as a guide for your bacterial sepsis. You have to rely on blood cultures. You may have to do 2 blood cultures, do it correctly, collect the right amount of blood as per the dictates of your bacterial culture bottle requirements. So that is very important for you to rule out sepsis. This criteria for bacterial sepsis goes out of the window when you're dealing with MIS-C. So I come to the most important slide now, that is how should you manage this patient. It's again a busy slide, so please stay with me. I'll take you through. On your left in orange, you can see the presentation, the worst of the presentation. When a patient comes in shock or multi-organ dysfunction, the first thing that you would do is to start this patient on methylprednisolone. Better, and this is confirmed, they've tried DEXA and all that, methylprednisolone is the ideal drug for patients of MIS-C presenting in shock at a dose of 10 to 30 milligram per kilogram per day with a maximum of 1 gram. Even if the patient is 80 kilos, you will still give 1 gram only, and you would give it for 3 to 5 days. Do you give all patients 3 to 5 days? No. If you, this patient, I'm taking you right down to this line, if this patient has improved clinically with resolution of shock and your inflammatory markers have improved, it can happen within a day. Then you can drop the dose down to just 2 milligrams per kilo. Do not give extra steroids, excess doses. We've all heard of mucormycosis and all problems related to steroids. So you should not give extra doses unnecessarily. So if you have not got a response, you may continue for 3 to 5 days of methylprednisolone. Along with that, you may need to give IVIG 2 gram per kilo over 12 to 16 hours. Particularly the patient is having cardiac dysfunction, you have to give longer duration of time. Now, IVIG is very expensive. A 5 gram dose costs almost 16,000 rupees. So if this patient is say 10 kilos or say 20 kilo patient who needs 40 grams, he is going to be, you're talking about something like 80,000 rupees. So before you give IVG, you must obviously counsel the parents about it. And if IVIG is not available or not affordable, then you can still give only methylprednisolone. Maybe you can give a slightly higher dose to this patient, but after parental consent, because these are the guidelines approved by Ministry of Health. When you do something which is not as per guidelines, you must have your butt covered. So you must ensure that you have taken consent and explained why you're not giving a particular drug. As you are aware, there's a court case going on by the South Goa Lawyers Association saying that certain things were not done as per protocol, and that is why they have filed the case. So we must all be sure that we are doing things as per protocol. So I've said we give methylpred, you give IVIG, you would definitely give empirical antimicrobials and aspirin. And I'll talk about aspirin shortly. So all patients get aspirin, all MIS-C patients get aspirin. If this patient has not responded, then you would go to, definitely when you go to higher dose, and you would give biologicals. In this patient, normal recommendation is tocilizumab. I shall not detail that. Next presentation is a KD phenotype. Here you will give IVIG and methylprednisolone, but only at a dose of 1 to 2. You don't give 10 milligrams to begin with. If the patient fails, you can then give a higher dose. Patient fails, for this patient, recommended is to give infliximab. In these categories, in broad, they're using anakinra, but we don't have anakinra here, so we stick to this dose. The most difficult part is this patients. These are the patients who I said to have come in febrile inflammatory state. They are not in shock, they are not in cardiac dysfunction, they are not in KD, and you're mild MIS-C. How do you proceed? These patients need to be hospitalized because they can go down suddenly. You must repeat investigations because you're not yet able to find whether this patient has got multi-system involvement or not. If while in monitoring this patient worsens into any of these arms, then your treatment protocol is clear. On the other hand, if he is not improving, then you have two options. Either this patient will deteriorate later on and have inflammatory markers going up, then you can start methylprednisolone, or he remains the same and maybe he will improve by itself. There is definitely cases of MIS-C who are self-limited and improve on their own. So that's another third possibility. If this patient, after you've given methylprednisolone, is not improving, be assured that you're not dealing with MIS-C. You have to look at other options. So stop antibiotics once cultures are sterile. Switch steroids to oral as soon as possible, and there's a guidelines for that. You must repeat tests as required. And very, very importantly, all these patients should have a repeat echo at the end of 2 weeks as well as 6 weeks, because many of BC patients develop coronary angio artery aneurysm. So that's why you have to follow up echo of all these patients of BC. As I said, aspirin, all patients of MIS-C should be given a dose of 3 to 5 milligram per kilogram per day. This is a dose so as to reduce the stickiness of the platelets, because many of them will develop aneurysms, and you should give to all 4 to 6 weeks. Once you confirm that there are aneurysms, you would have to wait for longer, maybe up to 6 months also. Of course, the platelet count is less than 80,000 or there is documented bleeding, you will not give aspirin. What about low molecular weight heparin? There are just 3 criteria for you to use low molecular weight heparin in pediatrics. Let me specify again, this is not adult patients, this is pediatric patients. Now, the tricky bit is when you have an obese patient who is 18-year-old or 17-year-old weighing 100 kilos, yes, of course, that patient may need to use low molecular weight heparin. But otherwise, if you have a low left ventricle ejection fraction below 35% or 10 aneurysm with a more than 10 Z score or documented thrombosis, you will use low molecular weight. And as I said, certain criteria, critical patients and these conditions, you will definitely use Clexane to this patient. The dose of 1 milligram per kilogram subcutaneous BID is a therapeutic dose. OD would be a prophylactic dose, and the duration is generally individualized. With that, having talked to you about all about MIS-C, I will illustrate 5 short cases, not very long, short cases. And these are all cases from Margao. So this is all from home. This is a 7-year-old child who presented on a Sunday morning at Royal Hospital. And I must tell you, this patient was a Sunday seen by Dr. Shailesh Kamath at Royal. And the RMO was instructed to call me and tell me that this is a child with a probable MIS-C. So Shailesh, I salute you. You were the first one to pick up right away. And that's a credit to our colleagues who are obviously sensitized. This child, 7-year-old, fever 3 days, high-grade fever, had vomiting for 2 days, 2 times vomiting with abdominal pain with a short duration of 1 day, rash for 1 day. There was COVID history. Child was febrile, nothing significant in the hemodynamics. The CRT was normal. The child was alert and responsive. Abdomen was soft. There was no tenderness guarding rigidity. So, would this be MIS-C? If you were in front of me, I would have just posed this question, but you are not. So let me go forward. Look at the criteria. Age is fine. Fever is there. There are 2 systems, GI and the mucocutaneous. So 2 systems. There is COVID. So 4 criteria fulfilled. Now we need to document inflammation and we have to rule out other conditions. Before I do that, let's have a look at something else. Pay attention to this child. This is going to be something very, very characteristic. And if you can see the eye of this child, this is typical KD hyperemia of the eye or conjunctival injection. What is important is what is known as a perilimbal sparing. If you see just around the cornea, the sparing of the capillary inflammation, it's all around it. This is very characteristic. So it's called perilimbal sparing, red eyes. Second important thing, there is no watering, there is no exudate, there is no crusting. This is not conjunctivitis. So it's important that you see this in patients. You are thinking of a KD-like picture. This child also had very characteristic lesions on the skin. This is known as a vasculitic rash, vasculitic, almost like a very, very big patches here and there at the back. So this was characteristic of a KD-like picture, and her test was showing that there was some amount of lymphopenia, CRP was elevated, borderline SGPT elevated, high ferritin, and obviously this patient was not affording. So I did not go about doing all the tests in this patient. And as I've already put all this criteria are fitting into this patient. So what should we do? We should rule out confounders, the only last criteria, which we did. And then I counseled the parents about the patient having MIS-C, having KD phenotype, and the patients opted for GMC because the cost was coming to about 1 lakh of rupees of IVIG in this patient. But this patient did not go to GMC. They went home because they obviously did not trust whatever I had told them. Unfortunately, the very next evening, this patient landed at Hospicio with hypotension and shock, needed to be restricted with normal saline bolus, vasopressors, and then was finally shifted to GMC, landed up in the GMC ICU, but improved there after getting all the drugs. Point is, this patient could have been handled at an earlier stage and not gone into a critical stage. So that is important. This is what is your KD phenotype, who can evolve into shock also. Next patient came on the same Sunday. This is a 9-year-old child presented at Astor Hospital on the Sunday morning again with a history of fever of 6 days, abdominal pain, neck pain for 1 day, had fever. You can notice that this child was having not much fever, but the heart rate was much higher out of proportion for this fever. For a 9-year-old, it is higher side. And also the respiratory rate was slightly on the higher side. He was saturating fine. CRT was okay. BP was fine. There was abdomen was showing generalized tenderness and guarding seen by Dr. Sujoy Das, but he saw clinically the child had red eyes with cervical nodes. He could fathom that this was a KD-like presentation of MIS-C. He called in the pediatrician. Dr. Sarvesh Kosambe looked at this child, and I must assure you that he did a fantastic job with this patient, managing this patient as per protocol, as I will show you ahead. Ultrasound of the child was normal, and therefore further on MIS-C workup was required. So lab tests were sent off. This child, while in hospital, found that this BP was dropping, the heart rate was rising up. So what should we do? Yes, normal saline bolus was given in the hospital. Quickly the reports were accessed, and you can see this child was slightly low platelets, very high CRP, borderline sodium, enzyme elevated, high ferritin, very high BNP, very high D-dimer, PCT was high, antibodies positive. Even an echo was arranged by Dr. Colasso came in and did it. It showed ectasia already on the 7th day of the disease. There was ectasia, not yet gone into aneurysm of both the lower ascending as well as the right coronary. This patient was hemodynamic unstable. So the blood culture was taken. First dose of ceftriaxone was given as per the surviving sepsis campaign. Second bolus was given. Methylpred was given. Adrenaline infusion started, and this patient was referred to GMC. This is perfectly as per the protocol defined for MIS-C, and this is how the patients have to be managed when they come in shock. That's the point I want you to show. This is your shock phenotype who comes like a surgical abdomen, but he was a shock patient. So it's very, very important to recognize shocks. I'm very briefly going to go over it. Remember, the definition of shock is when there is inadequate cardiac output to perfuse various tissues. Which tissues we can clinically look at? The brain, that shows as lethargy and drowsiness. Small children will come as poor feeding. Older children will come as dizziness and sweating. Kidneys will perfuse less, so decreased urine output. Skin will perfuse less, so therefore you have cool extremities. These are your symptoms they should always be looking for. And family practitioners, those with these patients, like I said, they may come suddenly, and you see such points, you know you're headed for trouble. And the sign will be disproportionate tachycardia, tachypnea, cool peripheries, feeble pulse, increased CRT, mottling, or sometimes the presentation could be in warm shock. It's called a vasoplegic, like a toxic shock syndrome, where you have warm extremities and you have got a flash capillary refill time, very, very red, bounding pulses. Don't be thinking this patient could be in warm shock. The final finding, BP going down, is your late finding. You must pick up the patient in the pre-shock state, not when the PP has gone down. So with that, I come to our next patient. This is also got a separate message to give us. This is a 9-year-old male child, 4 days fever, severe headache, meningeal signs positive. Family had COVID a month earlier. Clinical impression was meningitis. So counts were normal, but the CRP was very high. CSF MRI was done. It was normal. So are we dealing with a MIS-C in this patient? Investigated further. This patient started developing a feeble pulse, tachycardia, going into a shock-like state. His count showed up lymphopenia, low platelets, D-dimers were very high. So this looked like a MIS-C, right? Okay, but now we had to rule out other conditions. So to complete, before we gave this patient methylprednisolone, we looked at the other reports. Next day early, because this happened at night. Next day, strangely, the platelets had gone down to 90, not characteristic of MIS-C. And then we had NS1 positive. So the patient was actually dengue. Please note, Many times in your enthusiasm, you may want to fit the diagnosis into MIS-C. This was a shock-like presentation, everything fitting in by criteria. If you look back and see, everything would have fitted into MIS-C, but it was COVID. Sorry, it was dengue. And remember, D-dimer is high. We have never been testing D-dimers and IL-6 and all these newer tests in all our patients of enteric, dengue, or scrub typhus. So we really don't know what were these figures for those patients. So just by doing this exotic test, do not label a patient as MIS-C as you may want to. This is something that I would want to caution, that things can go wrong if you do not go by the criteria. Go as per the algorithmic approach, fit into the diagnosis, then only proceed further. What does the fourth patient tell us? 12-year-old, fever of 5-day duration, no symptoms, no other symptoms, had COVID last month, CRP was 64, increased, lymphopenia, so fitting in, all other tests were negative, no other systems, so this looked like a mild COVID. Couple of days later, child still remains fine, CRP is not increasing. What did I do? Just waited and watched for evolution disease. Patient was in hospital, repeat tests were done, reassured, and on 10th day, this patient fever settled, no medicine was given. This is your febrile inflammatory state. So some of these patients can settle down without medication. That's the message I would like to know, to give you. Watch out for hemodynamical stability. This patient has to be watched carefully, not just sent home when you have a clinical suspicion of MIS-C. And I bring you to the last interesting patient, again from Margao. This is a 15-year-old boy, big boy, 75 kilos. His name is M. I've just left him as M here. His fever and cervical adenopathy for a 6-day duration. Had COVID-19 a month ago. His initial investigations were non-contributory except for mild elevation inflammatory markers. Did not respond to antibiotic. All other usual suspects were ruled out. And on the 7th day of disease, he was found to be tachycardic, tachypneic, and orthopneic. So obviously distress had set in. His 2D echo was done, which showed biventricular dysfunction. Right ventricle involvement was more than the left ventricle. His D-dimers were very high. He had a X-ray showed a bilateral patchy consolidation. So with an acute deterioration with right dominance of a problem with a high D-dimer, there was a clinical suspicion of pulmonary embolism. So this patient was referred to for coronary pulmonary angiography, CT pulmonary angiography. There was no evidence of embolism, but there was pulmonary edema. There was some ground glass opacity in the perihilar region. There was bilateral consolidation. His echo showed again very large RA-RV. Ejection fraction is very less, 35%. There was tricuspid regurg, and LVEF was also reduced, but lesser than the RVEF. So this patient being in failure, improved transient with less X, and he continued to be distressed, orthopneic, requiring HFNO. So these were his findings. This was when he came, not a few days, just a couple of days back, high CRP on the day he came to Victor Hospital, high D-dimers, high ferritin, high BNP, liver enzymes affected with increased bilirubin, child was orthopneic, needed high oxygen, and you can see on next day, his indices had worsened, and you can see he was deteriorating. He needed now HFNO. So at this point of time, everything was looked at, reevaluated, reconsidered, thought that he could be MIS-C because he looked at all the criteria fitting in at this point of time. Methylprednisolone was given late in the evening of 29, and then what happens to him on 30th? CRP drops, the child is better, oxygen requirement is dropped, and the very next day, the CRP is dropped to 25, no distress, and he could be shifted out of the ICU. Very importantly, please note, D-dimer, the very, very famous D-dimers have dropped only with a dose of methylprednisolone. This is, again, please note, an inflammatory marker. I know I've taken a lot of time. Just a few slides ahead, just hang in there. I will just briefly tell you what MIS are. MIS, that is your an adult presentation. This is your CDC, and you have the very various types of case series reports from CDC. And I will just tell you very briefly, 23 median age is the interval for adults. The median organs, that is 4 organs get affected in adults. And unfortunately, even in abroad, they were unable to identify this patient at the beginning. What are the criteria they've given? They should have admissions. Unlike in pediatrics, these patients need admission, definitely COVID, very importantly, extrapulmonary system should be affected and there should be severe inflammation. Why did they exclude is because if you have a pulmonary involvement with severe respiratory involvement, then hypoxia related inflammation may not be able to rule it out. That's why they have excluded this. And many of these patients presenting at 2 weeks with RT-PCR, as I've already told you, becomes a special challenge. You cannot differentiate. Many of them will have lung involvement, and that becomes a basic problem. But what is important is that most of these patients will survive. That's a 95% survival. So in my concluding slides, I'll show you some practical tips. When you hear hooves anywhere, you must think of horses. Do not think of zebras, because these are uncommon cause of any sounding like hooves, which means do not think of uncommon conditions. I'm reminded of my professor, Dr. Amdekar. He always said, if you think of common conditions, you will be commonly right. If you think of uncommon conditions, you're going to be uncommonly right. So you're more likely to be wrong if you think of rare causes. That's an important message for all of us to remember. So please approach fever as in pre-pandemic. Think of other possibilities. MIS-C is a diagnosis of exclusion. If your patient is hemodynamically okay, do not rush with steroids. Please follow the algorithm. If your pro-BNP is high, expect trouble. Admit such patients. For pediatricians, children below 1 year, you must always more likely it's horses, more common conditions rather than MIS-C. Remember the age group of presentation. This is the characteristic age at which your patient will present. Usually disease does not progress beyond 2 weeks. If by the end of 3 weeks the patient is still having fever, probably you're not dealing with MIS-C. I'm reminded my patient last year who came and deteriorated on the 28th day, but still I will say this is a very, very unusual. That child was an unusual presentation and is not a typical MIS-C. We pediatricians do not use ECG more often, but many of these patients show rhythm problems, arrhythmias, conduction blocks. ECG is a very important tool in MIS-C. Remember this very important line: all the aneurysms and myocarditis, if all the different series all of the countries have shown, is reversible. So that's a good part of the story. If you are not having an elevated CRP and ESR by the 6th day, very, very unlikely you're dealing with MIS-C. So please remember that when you follow up, and if you need to follow up by day 6, day 7, your CRP is not going up, you should look at other causes. So, as I said, diagnosis of exclusion, allow disease to evolve if indeterminate and patient hemodynamic is stable. Always remember, as Sarvesh had done, you must send cultures first, then give antibiotic, then give a steroid, followed by IVIG. Methylpred you can give over half an hour. IVIG takes a long time, plus the cost is higher. Plus, steroids will protect you against the side effects of a biological agent like IVIG. Before you give IVIG, save a serum sample, because you may have burnt your hand. You have to look for other causes later on. So it's practical to save a serum sample before you give IVIG to a patient. Survival rate is more than 90%. I know I've taken a lot of time. I promise you, this is my last slide. As I said, in case, how would you approach to my GP friends? Also, as a practical approach, what should you do and what would I do? If I see a patient in the first 48 hours, I will only give paracetamol after ensuring that the patient is active and feeding well. By day 3, the child has to be examined, and I would look for focus of infection. Is this a viral? If the child has cough, remember, cough is not a feature of COVID. So cold, cough, running nose, viral disease. You are not looking at MIS-C, tonsillopharyngitis, acute otitis media, lower respiratory infection, tachypnea, and a patch of consolidation I can examine on clinical examination, or a urine infection rules out MIS-C. I'm not going to look further on. But if I see KD feature in a child, I am looking at definitely MIS-C presentation. KD features I already elaborated to you about a while ago. On the 4th day, I will look at this basic test. Please note, I am not asking for COVID, because COVID antibodies presents, I need not do first. I want to be sure I'm dealing with inflammation. To me, the most important thing is CBC, ESR, CRP. Only if positive, I will go forward. Please remember, this is a hemodynamically stable patient I'm talking about, not a hemodynamically unstable patient. Hemodynamically unstable patient, you work up the whole gamut. I will rule out the common malaria, dengue, urine infection if this patient is stable, and if this patient follows this criteria, then I will look at the other criteria. If it does not come positive, then I will look at all other common infections. As promised, that was my last slide. You survived the talk. Those of you who are awake, that is, those who are sleeping, you can wake up now for the very nice presentation Priyanka has lined up for you. Thank you very much.
Thank you so much, Dr. Harshad. First of all, I think all of y'all will agree with me that Harshad is an excellent teacher. Isn't it? I'm sure everybody will agree with me. So I request Dr. Thanks, Harshad. Thanks for a very elaborate talk and amazing explanation. Dr. Priyanka, will you please take the questions? And
is my slide screening out or is still there?
No, it's we can't see your slide now.
All right. Okay. Fine. Sure. Thank you.
Dr. Priyanka.
Questions now, so I would ask to kindly ask questions directly because there are no questions in the chat box. So I would request participants, the delegates, to kindly ask questions directly to Dr. Harshad.
I have a question for you, Harshad.
Yes.
You said the aneurysm is also reversible. The very pathophysiology of the aneurysm is weakening of the wall, right?
That's a very important and interesting question. Now here, unlike in Kawasaki's disease, where there's intimal damage and necrosis causing aneurysms, in this situation it is not so. So it is not that you have got necrosis. Therefore, whatever has been seen, and these are studies all over the country and abroad, that majority of these patients, and we are still talking about a short duration, 90% of all these patients have reverted, even if the aneurysms were 10Z score and above. When I say 10Z, just for a perspective, less than 2Z score is normal. Between 2 to 2.5 is called ectasia. And only about 2.5 to 5 is called mild aneurysm, 5 to 10 is moderate, and only about 10 is severe. All patients, even with 10Z scores, have reverted. Majority, I said 90% have reverted. Whereas in KD patients, about 30-40% of them don't revert.
Okay, so that's something.
I have skipped the pathophysiology, obviously, but the pathophysiology here is different.
Okay, thank you for that. Any other questions? I think you can unmute and ask the questions.
Yeah, Dr. Harshad.
Yes, Praveen.
That was an excellent presentation. Just a few points. In fact, recently we have come across a couple of cases of Miss A. I'm talking about adult.
I actually just put the slide up because I'm sure there would be a lot of my physician colleagues would want to share their data. In fact, the case that I presented to you was also from the physician, because this was not by the pediatrician, it was managed by the physicians very, very properly, I might say.
We still feel basically ARDS still remains a presenting feature. They have some sort of new onset fever, and all your workup usually comes negative. D-dimer, CRP, and other markers remain elevated, and they respond wonderfully well to methylprednisolone. I think that is what has been the observation. I have not had any patient to be administered IVIG as such. I also don't know, maybe somebody else in the audience can share their experience.
So that's a very pertinent observation, and I'm sure many of your physician colleagues will concur that it becomes a big dilemma. See, you have patients, adult patients who have already got lung involvement. Now the question sometimes, like this patient that I presented, the ground glass opacities might be remnants of the previous COVID active disease. Radiological clearation takes time, whereas our pediatric patients come with clean lungs. So our diagnostic dilemma is lesser. So with adults who will present with cardiac dysfunction, already in pulmonary edema, now the whole picture becomes different. You already will have these group of patients become confusing. But at the end, if you looked at in totality the patients presenting with deterioration after 2 weeks, because all other patients with having patients with cytokine storm comes in the second week. Those who come in the third week of disease, that is when you start thinking of MIS-C. Therefore, the time frame is important. Also, these are the patients who initially would be fine. Respiratory discompensation happens in the third week, and you will have very high inflammatory markers. not responding to your initial DEXA, which is small doses that you give, that is when you start thinking. And you can see 1 dose of methylprednisolone or 2 doses of methylprednisolone, fantastic response that you will see. You don't get that response, you have to reevaluate your options.
Correct. Fully agree.
And what you said is, if you don't get a response with 10 mg, you can go with 20, you can go up to 30. But the point really is that the moment you get a response, please drop the dose as fast as you can, as was in the index case, patient 5. This patient was jointly managed by Dr. Rajesh Javarani, Dr. Rajeshwar Naik, and Dr. Vinayan. So I'm sure if they are there in the audience, they might want to give some perspectives on this patient also. As you said, collective wisdom is important from collective contribution. I think it's important for all. It's very important for all the physicians here to obviously tell us, all us also, their experiences. So if anybody would like to share their experiences, please go ahead.
Yeah, hi, Dr. Harshad, Dr. Rajesh Javerani.
Hi, Rajesh.
So, yeah. So this is about the same case that we had in our ICU. This is one 16-year-old boy, post-COVID, after a month, presented with fever and evidence of myocarditis. And to our surprise, all the inflammatory markers were raised: CRP, D-dimer, and ferritin. In fact, the D-dimer was more than 10,000. And we first thought that patient had embolism, pulmonary embolism, and the CT angio was normal. And then, in fact, when I discussed with Dr. Harshad, and then we realized that actually we are dealing with this condition called MISC. And the moment we put them on methylprednisolone, to our surprise, the CRP, which was more than 300, came down to 25. And in fact, the D-dimer, which was more than 10,000, with just 2 doses of IV methylpred, came down to 1600. I mean, so drastically, which I would not even expect with low molecular heparin. And in fact, there's not much role of LMWH in these cases. And as Dr. Harshad said, in fact, we should add aspirin for some time. I don't know how long should we be giving aspirin, Dr. Harshad?
4 to 6 weeks, but you need to do your echos at 2 weeks and 6 weeks. If that patient starts developing aneurysms, which many of them do, then you may have to give for 3 to 6 months also. Same dose.
Also, one important fact that I realized was that the dose of methylprednisolone has to be correct. If you give a underdose, perhaps you may have a clinical response at that moment, but you may not prevent the coronary artery ectasia or dilatation later on, and that may cause problems later. So I think the right dose of methylpred on day 1, day 2 has to be very important. Am I right, sir?
Perfect. See, the whole point is, let's understand one thing. These guidelines have come from the American Rheumatological Association, because initially they were taught like KD, that's Kawasaki's disease, which is in the realm of the rheumatologists. So the guidelines came from them. And for KD, our primary drug is IVIG. But all along, we are realizing more and more that it's steroids which are the most important drug. And we need to hit it right, because it's a super inflammatory state. If you give that small micro doses, you may not be able to revert it. But if you give the right dose, the debate has still gone whether you should give 10 or 30, but the consensus is now coming towards 10 to start with. No response, inflammatory markers not coming down, no response, you can hike up the dose to 30. But in any case, the dose can't go above 1 gram. 1 gram is the max you can give, as we gave to this patient that Dr. Rajesh is talking about.
And so this patient clinically has improved so well, then within 48 hours, he's out of the ICU, he's off oxygen, and he's absolutely clinically much better. I mean, the response was dramatic. So it's the right diagnosis at the right moment that is very important.
Perfect. That's perfect.
Thank you.
Harshad, I have a question here. In adults, we don't give aspirins, okay, as far as COVID is concerned, but low molecular weight heparin is preferred. But here in pediatric cases, why is the reason that you prefer aspirin?
No, I am not talking about COVID-19. We are talking about MIS-C. Let's not confuse the issues.
Okay.
MIS-C is a different pathophysiology altogether. It's an inflammation, whereas in COVID-19, you have a vasculopathy which is going on, And it's a very interesting thing that I heard, and I'm sure that I would like to share with you. See, we in pediatrics have a condition called hypoxic ischemic encephalopathy. COVID-19 is best described as hypoxic ischemic pulmopathy. So in that case, in COVID-19, you will find the problem is with, as you know, the pathogenesis. That is where the vasculopathy is going on. So there is thrombosis there. You will use enoxaparin in that case. I'm not talking about that group. I am talking to you about a situation where the D dimers are high as an inflammatory markers. It's not the same. It's very important that you discern the two, because the diagnostic purpose and the treatment purpose. So D dimer if you diagnose MIS-C, and you have to use, you'll use both. The aspirin, as I said, is so that you will not have problem with aneurysm later on, because there is the platelet stickiness goes down. That is why we use a low dose. We just use 3 to 5 milligram per kilogram, maximum 75 milligram, no matter what the weight is.
Thank you for that.
So,
Any other?
Harshad, extension of the same question. In the third wave, are you more worried about COVID affecting the children, or this MIS-C coming up little later? I foresee ICUs getting filled up maybe 2 months post the third wave.
So let's look at this first way. First of all, and on this forum, the maximum incident of MIS-C is usually about 4 to 6 weeks after the peak.
Yeah.
The peak has passed. We are at the time, so most of the cases are going to come now. Tomorrow, someone of you might see this. This is the time we are going to see MIS-Cs of the last second wave. Whether the third wave will come, we have already debated a lot on it. I personally, my gut feeling is that if we manage the vaccination well and we manage all other aspects and the COVID, probably we'll have a muted third wave. Let's wait and see how it goes. But if the third wave does come and a lot of children get affected, we will also see a few more cases of MIS-C later on, but probably not more than what we are going to see now.
Dr. Harshad, any cases of MIS-C after vaccination?
Not at all. There's no connection at all. See, MIS-C is basically inflammation to the virus, because the pathophysiology is antibody-dependent enhancement. Now, vaccine, as I've already said in the past also, has looked at, now let me just go back to the point. In this response, there's a TH1 and there's a TH2. TH1 response is desired, the one that we want, good response. TH2 is an inflammatory response. So ADE is a TH2 type of response, that is antibody enhancement. These vaccines that have been developed with a technology whereby the adjuvant added, particularly to Covaxin, shifts this patient's the immune response to TH1, not TH2. So you're not going to get ADE with Covaxin, which is the whole virus. On the other hand, Covishield has got only one antigen, anti-spike. It's not a whole. So therefore, you're not going to see ADE-like presentation even with Covishield. So please, let's not worry about a vaccine causing MIS-C at all. And the proof of the pudding is that as the vaccination has proceeded all over the world, the MIS-C cases have not gone up at all. Am I audible?
Very much.
Rajesh, I hope I answered your question.
Yes. Thanks a lot, Dr. Harshad.
Okay.
Thanks.
Any other questions from the audience?
Question,
Yeah, Priyanka.
Dr. Harshad. Yeah. So since you said that the duration, the time period for MIS-C is usually 4 to 6 weeks post the COVID infection. If a child comes to us 2 months or maybe more than that, with similar complaints, with clinical features, with the parameters which are raised, should we still consider it as MIS-C or dig into more diagnosis?
That's a very pertinent. That's a very pertinent question, Priyanka. See, the whole point is maximum. The mean median mode will come between 2 to 6 weeks after the COVID, but up to 3 months is accepted a general time period. Now, but here is the problem. How do I know that the patient has got exposed when? Because they is asymptomatic. Most patients are asymptomatic. So really the timing as to when the disease happened to the patient is very difficult. We cannot assess it by the level of the antibody. Also, another point for it not to be antibody dependent enhancement is because many of the MIS-C patients have borderline antibody levels. Some have very high antibody levels. So there's no correlation with the timing of the disease. So the long and short is that 2 to 6 weeks after the disease is the commonest duration, up to 3 months is the when is maximally described. But if supposing somebody comes 6 months later, fits on the criteria, there's no way I will not know that the patient did not have a second exposure to a COVID patient in between. And at the first instance to a different variant, maybe 6 months back he got exposed to a different variant. 2 months back he was asymptomatic, did not. So we cannot be sure that the patient who comes at 6 months is not COVID, is not MIS-C. So that is why I said those criteria cannot be very, very strict. They should be taken more as a screening criteria. And if everything else fits in, everything else is ruled out, then you consider MIS-C as a diagnosis. I hope I have not confused. I have answered the question.
Thank you.
Yes, Praveen.
One last question, Harshad.
Yes.
What I understand is children's, they have less of H2 receptors.
Correct.
Also, they have a very good T cell response.
Correct.
That means even if they get a disease, it is going to be very mild. So what I'm trying to project is in the third wave, we are going to see less of COVID-19, the extension of the same earlier question, but more of this sort of MIS-C
So
later on. What is your take on this? Yeah.
Now I can tell you, I have seen 5 MIS-Cs so far.
Yeah.
All 5 patients had no recollection of having had COVID, which means they were all asymptomatic, which
Okay.
means almost everyone, this is universal observation, all MIS-C patients are either asymptomatic or very, very mild. So it doesn't matter if you have COVID by large numbers, you will have a higher risk of MIS-C. It is
Yeah.
not that they have to have severe disease. And there is one since you're on the topic, there is one pathophysiology which I've sort of skipped over. It is believed that when you get COVID, because of less ACs, there is no inflammatory process, and by various cycles, the inflammation does not skips the lungs and goes later on to hit all other organs, and that is what is shown as a macrophage, phagocytic dysfunction, innate immunity imbalance, all that is described. So to answer your question, if the third wave comes, a higher number of children are affected. Yes, they will all get milder cases, vast majority milder, but these mild cases are the only ones who develop MIS-C, not the severe ones.
Yeah, but this is the same opposite in adults. What we find is those who had a severe sort of illness are the ones coming little later sometimes with sort of a new onset fever, ARDS. That is what is the major difference, looks like.
Yeah, so basically older patients are more inflammatory by nature. So it's all a question of who are more inflammatory. And that is what is the whole key here. You have a higher inflammatory personality, he gets more cytokine storm, and they are the same ones who are likely to develop. So that is the dichotomy between our patients and the peer adult patients.
Absolutely, absolutely. Thank you.
Any more questions for Dr. Harshad from the viewers?
I think it's we should end this on this note, Dr. Harshad.
Thank
And
you.
thanks for taking all the questions. Thanks for everything. Thanks for a lovely lecture and making all the concepts and the myth about MIS-C very clear. So thank you for that. And now on to you, Dr. Priyanka. I'm sure you're waiting for the video that you're going to release. Thank you so much.
Yeah,
Guys,
thank you so much.
enjoy the video.